I'm Jerry Hesch. I'm teaching a workshop in North Andover, Massachusetts, and we're talking foot and ankle, and Kevin is a soccer player, and he apparently sustained an inversion injury because we find that he has greater inversion range of motion on this ankle, which looks to be about 25 degrees, and in contrast to this one, which is 15 degrees. I can overpressure it, and then I still get extra movement. So I would call that laxity of his fibulocalcaneal ligament. The fibula has dropped inferiorly, and so comparing side to side, it's very easy to see this malleoli is inferior. And when I hook the right malleoli, I can spring easily. I can translate movement through the ankle joints, and it translates through his body, but on this side it's stuck. I can't get movement past this joint to translate into the rest of the body with a reasonable amount of force. Okay? Now he has to compensate for this somewhere in his body. And the place where he compensates is up high. So he basically has a longer leg on that side because he's walking in inversion in the left ankle, subtalar joint. I can look at him and I can see his head side bent right. If I put my fingers, my index finger under the mastoid, I lift up on the left side and he side bends to the right easily. I lift up on the left, there's no movement. With the same amount of force, a reasonable amount of force with my index finger, there's no give. So he is side bent right. This is a muscle phenomenon driven by the nervous system. It's reflex. It's driven by a reflex. Now I'm going to show you something interesting. So his head is going into side bending, so his nervous system is participating, and he's going to be strong in that direction. Side bend to the right. Show me how strong you are. He's pretty strong. Okay? We tested this a while ago. Now we're going to do the same thing on the left. Don't let me side bend you. Look at what he pulls in. Isn't that amazing? So this really is a whole body phenomenon. So his ankle affects his core, it affects his body all the way up to the occipito-atlantal joint. So this is a muscle phenomenon. It's not a joint restriction. I don't have to mobilize the OA joint. I need to mobilize that fibula into superior glide. And what I'm going to do is hook the fibula, and I'm going to use a little more force, and I'm going to go 30 oscillations. And we'll keep filming. So I'm using more force than what I used on the left side. And I feel like that's gaining mobility. Okay? Good. So I come back and I retest it, and now you can see the body moves when I spring vertically on that fibula. So now I'm going to test posterior glide. I'm going to push the malleolus towards the floor, and I like to do that with my thumb, and there's good play there, so I don't have to mobilize it posteriorly. Let's have you lie on your stomach. Sometimes the fibular head will be posterior, so I bring the feet together to control hip rotation, and I identify the fibular head on the posterior aspect. They feel very symmetrical. With my thumb, I can induce a little bit of spring, a little bit of joint play on the right, and I can do the same thing on the left. So there's no need for me to mobilize it forward. We just treated another person just before Kevin, and we had to mobilize the malleolus posteriorly, and we had to mobilize her fibular head anteriorly. So we recognize patterns, but we also should have the skill to know when someone doesn't fit the pattern. So I'm not predicting what I'll find and then finding it. I have a predictive model, but if it's not there, it's not there. So I'm not fooling myself. Do you understand? Okay? So lie on your back. He's lying symmetrically. And now when I side bend him left, he moves very easily. See how easy that moves? I'm just lifting my index finger against his mastoid. Now I'm going to test your strength on the right side. Go. And you were very strong before, and you're strong again. And now we're going to test you on this side. little bit of pulling in, but more, certainly a big improvement. Let's do that again. It goes right. So you can see it just a little bit. Okay, and then left. A little bit of an adjustment, but distinctly different. Can you see the difference in that? In his muscle recruitment?
Yes.
So this is a whole body course, and this is an example of how an inferior fibula influences the upper cervical spine. And I need to look at his range of motion now, and now I invert him, and he's about 15 or 20 degrees, so that's less motion now. Let's have you walk up and down the way and tell us how you feel.
Feels a little more symmetrical and easier, like lighter.
Oh yeah? Good. Sounds positive.
Sounds positive.
I'll take it. Very good. Thanks so much.